Hello everyone, this is Dr. Khan, Executive Plastic Surgery, Bloomfield Hills, Michigan. So we're here at the hospital today. This is a very interesting Facebook Live. A nice patient from out of town, out of state, comes in with a set of implants from 2005. And so she had kind of contracture, she had the symptoms of breast implant illness. And she and I talked on the phone, and then I saw her on Friday. Because of her underlying medical health, BMI, we were able to do the surgery at the hospital because this is one of the criteria to come here at the main hospital, which is right across from us. So as you will see, 2005, 12/8/25 initials LD. I did a lot of contouring. This is on the right side, a lot of skin removed to help with the contouring. And the distance from the nipple all the way down to the crease, from the nipple areola complex skin all the way down to the crease is the same on both. And as you can see, this is an en bloc, complete removal of the entire implant capsule, all inflamed tissue. If you look at it, this is more oval shape. This is more hunched up. And different, and so this inflamed tissue around has been removed because if you feel it, it looks abnormal, palpates abnormal, it's nodular. Look at the way this nodular fat is, and so I didn't like it, and so I incorporated it along with this tissue. Now, she had an MRI done a couple years ago that showed that the left one is ruptured. We do not know, maybe in the last 2 years this one potentially ruptured. So we always assume, these are all implants, 20-year-old set of implants, that she could potentially be ruptured on this side, and she has what are suggestions of what is a rupture. So according to the MRI from 2 years ago, this is an intact implant, but I always assume all implants are ruptured till proven otherwise. So as I go in, you will see en bloc, the gold standard. As I go in over here, a lot of inflammation. And as I remove this, this is, if you look at this, this is suggestive of, if I press over here, this is a ruptured implant. So as you can see, now this is clearly being ruptured on the side and the periphery, everything contained, and you can see the color of it. And this is where, if you look at the shell of this implant, it's a different material than the inside. And this is certainly what back in the day used to be banned unless you were part of an experimental study. And this is your implant that is from Mentor 350cc. So had I listened to the MRI, I would not have known. I always assume the worst, so that as we go into the case. And now as I look into this tissue, you can see a lot of this inflammation. Look at this. You can see my blue glove. This is how thin some areas are, some areas relatively very thick. What I'm going to do is I'm going to cut right through this because I want to see what this is. Remember, this is all this irregular. You can see the color of the fat is not healthy, and all of this scar tissue has been removed. This is inflammation. In the past, it has come back as fat necrosis. I cannot tell what it is or what it is not, and that's why we are at the mercy of the pathologist. So I'm going to go ahead and remove my top sterile glove, and I have another pair of gloves sterile. It has to be sterile because I'm going to take cultures of the biofilm on the inside. And I am going to now focus on the left side. You can see the contouring. I removed a lot of the skin. Remember, this is not breast tissue. This is not breast tissue. This is just the skin axis given her BMI. And the distance from the nipple areola complex to the crease is 4.3 centimeters on both. And as you can see, all contained, everything removed, extreme amounts of inflammation. And as I cut this open, done en bloc, you will see how it's going to eventually declare itself. Now we know from the MRI, which is the best test, that this is going to be indeed ruptured. So as you can see, this is supposed to be Y end block. So there was a question over the weekend. Someone said, why do you always have to do an end block? It's a cancer term. No, the word end block is done so that none of this spills into the chest. And that's why everything is contained. Now it's an oncologic term, but you can see how it's molten. This one recently ruptured. This one has been ruptured for at least 2 years. And you can see everything has been contained. That's why you want to do an end block. You want to be thorough, you want to be meticulous, you do not want to be second guessing the process. You want to do it right, you want to do it complete, no matter how thin the capsule is. So none of this spills into the chest because, as you can imagine, once it's spilled into the chest, it's too late. Look at the inside color of this. I'm just going to bring it over. Look at the inside color of this. It's a little bit on the brown side versus that one that looks a little bit more pink. And everything over here has been removed, contained, all the badness. Remember, there is not only the implant, but the capsular tissue. That white, glistening white, for example, but that fatty tissue around that's also inflamed that has to be removed as well. In my practice, I remove it because that silicone has very likely leached into the periphery. So she indeed did get what is the best surgery that anyone can get because none of this spilled into the chest. Look at the way how it's melting away. As you can see, they're not lifetime devices. Mentor 375, just like the opno, just like the paperwork said. Everything contained, none of this spilled into the chest. All this badness removed. Remember, anyone can remove implants, but it's all about this capsular tissue and all that inflamed tissue around it. I'm going to say it one more time. It's not only about the implant plus the capsule, but that inflamed tissue around such that everything is contained. None of this spills into the chest. And 20 years from now, I cannot imagine anyone else doing the surgery any different, any better. I'm going to go ahead and take cultures from the inside. Remember, these are my sterile gloves. These are my sterile gloves. I'm going to get cultures from here. This is the best sample. I'm going to send the whole capsule off. So the implants will be returned to the patient. Capsules to be sent to pathology, rule out the rare BIA, LCL, CD30 analysis, rule out the BIA, which is the breast implant associated, SCC, squamous cell cancer, breast cancer, the ALCL, anaplastic large cell lymphoma. Cultures for aerobic, anaerobic, and fungal. I'm going to send the skin samples off as well as the right breast excess skin. Remember, it's not breast tissue. All the good, healthy, viable tissue remains behind. All bad tissue removed. This is done consistently with the right mindset that all implants are ruptured to proven otherwise. And number two, the right skill set so the bleeding is minimal. Literally 5 cc's on the right, 5 cc's on the left. No need for drains. No need for that unnecessary lift, especially given the severe inflammation. Look at this again, this brown duskiness that's present. All of this inflamed tissue removed completely. And ultimately, if you ask me, the best and the only way, not only to see this end block, but most importantly, you have to see the high definition pictures and videos of the chest wall showing complete removal of the capsule. If you don't see that, your surgery was not done in the manner as described. And so it is extremely important that the surgeon is very transparent, describing how he or she has done the surgery, what is the goal of the surgery, and that there is complete workup so that we know from microbiology and pathology that there is everything removed and everything was tested. And I have the best anesthesia team here at the hospital. Just like we reproduced it in California, we do it here in Bloomfield Hills, Michigan. And we're right here doing our surgery so that all the goals of the operation have been met consistently from one patient to the next, regardless of the comorbidities, regardless of the reason why the patient is here, the nice, wonderful patient. She did her extensive research and homework, and I'm going to say she would not be happy with how the surgery has gone, which is what exactly we discussed. So this is Dr. Khan, Executive Plastic Surgeon.